Right, so thank you first of all for inviting me. Thank you, Deirdre. And what I'm going to talk to you about is discussing some strategies for reopening of schools and how they balance with the test and trace intervention, and what does that tell us about the risk of occurrence of a secondary epidemic wave in the UK. Okay, I'll give you a brief, just one slide, because we all know, and people know more than me about the COVID burden and the current situation. I will give a brief description of the model we are using, which is the COVASIM model, and then I'm going to talk about the application of COVASIM to this work, and then discuss briefly some ongoing and future work. So, as of 27th of August, when I was finalizing my talk, there have been over 333,000 confirmed infections and over 41,000 confirmed deaths in the UK, and this is the data from this website. Since the beginning of the epidemic, there was an exponential growth to start with, followed by the nationwide lockdown in the UK and across different countries. And as a result of this, as of March 19, an estimated 1.6 billion children and young people in over 180 countries stopped attending school. And in the UK, during the lockdown, schools were generally shut, apart from remaining open for children of key workers and children with defined health, education, and social needs. There were estimated 2% of school children attending during the lockdown. While any intervention that reduces number of contacts, number of social and physical contacts, including school closures, can reduce onward transmission of respiratory infectious diseases, and including COVID. They can also cause considerable harms, including damage to children and young people's education, development, physical and mental health. They can cause social isolation, and of course, by keeping the schools closed and keeping the parents not able to go to work and the society closed, there is a danger of reduced economic productivity. Under current plans, primary schools and secondary schools have already reopened in Scotland and are returning to England, Northern Ireland, is returning to school in England, Northern Ireland and Wales today, this week, and from September. Mathematical modeling. So I'm a mathematical modeler for about many years, shall we say, and it's very, very exciting to see mathematical modeling being so much used. It has always been a tool to answer complex questions because it gives a defined technical framework where various scenarios can be simulated and different interventions evaluated. Mathematical modeling in the context of COVID has been important in exploring different scenarios, exploring different interventions, and therefore helping advise policy decision makers during this pandemic. There are many mathematical models, and in the context of the epidemic, me together with my group of collaborators have developed at least 3. COVASIM is one of those. COVASIM, so what's different about COVASIM as a mathematical model? Well, like most models, COVASIM is a tool for answering specific questions. It's an individual-based model, and therefore it is best for modeling complex scenarios and countermeasures interventions. And it's especially good because it's individual-based and it's very stratified. It allows mixture structure and detailed interventions to be evaluated. So just a little bit of sort of an introduction to what can we do with it. So this is the work. So at the moment, COVASIM, as you will see on my last slide, is used in a number of countries. For example, in Seattle, we are asking certain questions. And the next slide you'll see in Australia, we are asking different questions. And in the UK, we ask different questions. So, but typically, COVASIM we are using as answering typical policy questions from around the world. For example, how much testing do we need to do? And what about contact tracing? Do we balance these two? And how would answering these, how would these change if things open up more? So, for example, this is an answer for Seattle, and these are some detailed simulations we have run for producing the effective reproduction number for these scenarios. The work is currently as a preprint and in review in a high impact journal. In Australia, we asked how many people would need to be contact traced using an app for the intervention to be effective. And again, how would these things change if the society reopened more? So we were doing this work before the second wave hit Australia, and our results are helping policy decision making there. What about the UK? This is the work that I'm going to talk about today. And the typical question that we ask here is it okay to open schools? We asked in May, later this year. And if we do, how do we do this safely? I will talk to you about the answer and how we got to it in the course of this presentation. Just briefly, because I'm sure that people will ask me, and I'm happy to follow up with details about what the model does and how it does, but there are three components of COVASIM. There is a disease progression and transmission, where individuals progress to the disease states of susceptible, exposed, different stages of being infectious, recovered, and dead. And this progression depends on age and comorbidities. And there is a disease transmission where viral load varies or changes over time and individuals, and this affects transmissibility. The second aspect is we consider individuals, and individuals are part of networks. And the four networks we consider in the model are household, schools, work, and then a community. And within community, we can consider stratified settings of social care settings, different parts of community, other custom networks that we would like to build, stratify them within the community setting. We have an age mixing pattern, and there is an interaction of movement between people within these networks across the model. The important thing, the third component of COVASIM, is the interventions. And specifically, it was developed in order to look at test, trace, and isolate strategies, because then the interesting part there is that the contact tracing individuals rather than a population-based models where the tracing of individuals is slightly trickier. Although we have also developed a model that has done this in details with collaborators from Edinburgh. On top of simple extension to look at testing, tracing, and isolation strategy, we can look at these in conjunction with incorporation of other non-pharmaceutical interventions, such as wearing masks, keeping social distancing measures, hygiene, etc. It's important to note that reopening of schools was one strategy we were looking at, and we're also considering how would you reopen schools and have trade-offs between different aspects within the networks that I talked about. We are developing this as we go, and there is an app that we've developed, and you can play with it after the presentation, or I can talk to you more in details. Okay, so moving on to what the application I'm talking about today is the application of COVASIM to the UK. The work has been published in the Lancet Child Adolescent Health a couple of weeks ago. The idea behind this work is that reopening schools is the first step to reopening society, and it's important to evaluate the impact of this on the risk of second wave potentially coming later this year. Auto-published studies have looked at epidemic spread and different interventions. What we have specifically looked at reopening schools in the context of reopening society. We have, through the course of our work, explored reopening schools and not reopening society, but we feel that these things go hand in hand because reopening schools allows parents to go back to work and allows greater social interactions within society. The overall aim or objective of our work was to estimate the level of testing needed for a specific level of contact tracing or across levels of contact tracing to avert a second wave under two different scenarios of reopening schools, full-time and a rota system. Of course, the decision and the current policy is that the schools are reopening fully, but we did this work not knowing what the policy would be at the time we were doing it. So just briefly, a little bit of sort of schematic that incorporates the slides that I talked about, the different components of COVASIM. So on the left-hand side, we have the different network structures we considered, and on the right-hand side is the a very basic schematic of the progression of the disease, progression of people through the disease states in the model. Again, I'm noting that this is an individual-based model that simulates transmission between individuals over time. Details are in the MetaHive preprint, which is currently in submission, and there is also details on the specific adaptation and application in the supplementary of the published work. Okay, so because people are interested how well we fitted the data, we calibrated to confirmed cases, and that's in the UK. The published work is calibrated until the 17th of June 2020. We have since then recalibrated until 2 days ago, and this is work that is ongoing. We simulate, importantly, 2 different school reopening scenarios, representing a full-time and a part-time rota system, with half of the students attending school on alternate weeks and or attending full-time. And we estimated the testing, the minimum testing level needed for 2 different levels of contact tracing. The choices of the 2 contact tracing levels lie in the fact that we have, we were modeling a more optimistic and a more pessimistic coverage of the contact tracing. Okay, a lot of words here, but I've kind of already said most of what is here. We are modeling opening schools as a first step towards reopening society. As these models do, we estimate the number of new infections, cumulative cases and deaths, as well as the effective reproduction R. We look for robustness of the model, and for this purpose we look at uncertainty around infectiousness of children, and we simulated 2 different strategies, 2 different scenarios. And the first scenario was looking that the children and the adults had the same transmissibility or infectiousness, and the second scenario looked at children being half as infectious as adults. We have ongoing work that has been recently accepted at JAMA Pediatrics that has collated all the literature to date on this and has run a meta-analysis on it. Okay, so this is a schematic of a potential of what would happen as we increase the testing level for a specific level of contact tracing. What I'm going to show you is that as we increase the testing level, we see that there is a possibility of controlling the second wave, and as testing level increases immensely, then we have potentially a full control and a suppression of the second wave. Now, the testing level that I'm talking about is the testing of symptomatic people over the period of their infectiousness. And what we see is, again, we see that we start off with around 28%, which is roughly the testing level that it is that is currently when we calibrate the model to 2 days ago. And we, with that testing level, we start, and then as the testing level increases, we see that the second wave may be suppressed. So what our results are showing is that the reopening UK schools in September must be combined with high coverage of a test, trace and isolate strategy in order to suppress the second wave of COVID. Okay, so what happens if we run all possible combinations of tracing success rate and a symptomatic percentage of people tested symptomatically? So what I'm showing you here is heat maps or faceplane diagrams that plot the peak of the new infections, so the peak that you saw in the previous animation, and the cumulative deaths as we go on the x-axis from left to right in increased tracing level, and on the y-axis from the bottom to the top with an increased symptomatic testing. So what these graphs, I mean, there is a lot of information in these graphs, but what I'm trying to illustrate is that if we are in the blue region, then we have a lower peak of new infections and a lower peak of cumulative deaths. And then this increases through the blue, orangey, and towards the red region. So there is a balance between the level of contact tracing and the level of symptomatic testing that needs to be achieved in order to gain control over the peak of new infections and control the cumulative deaths. The equivalent graphs to these we produce for cumulative cases or infections and effective reproduction number. So overall, what's the message? The message again is that we need to have adequate test and trace combination in order to keep this peak of new infections down, control the number of deaths and also the number of cases, and keep our effective reproduction number less than 1, hence avoiding a second epidemic wave in the UK. These are the graphs that you have seen if you have read my paper, and in this, so these graphs are suggesting that for picking up some values of test and trace combinations, we get a second wave or we don't get a second wave. And equivalent to those graphs of the new infections, we get a temporal behavior, temporal profile for the effective reproduction number. As you will see, there is more uncertainty around this because as the reproduction number goes down, the uncertainty around the measure and the metric that it is becomes uncertain. So in summary, what we have tried to do is we have evaluated, used the mathematical model, and we have looked at different combinations of test and trace. And for the specific ones that we discussed in the paper, if we assume that 68% of contacts could be traced, calibrating the model until 17th of June, we estimate that 75% of those with symptomatic infections would need to be tested, diagnosed, and isolated as schools reopen in September. And if the tracing of contacts is less, then the testing required is more. So it's in a sort of summary way of that result, that what we are saying is that it is possible to potentially avoid a second epidemic wave if enough people with symptomatic infection can be diagnosed, their contacts effectively traced and isolated. However, if reopening schools happens without an effective test, trace, isolate strategy, there is a danger of a second epidemic wave later this year. This is sort of two results. So the results that you have seen in the published work, calibrating until 17th of June, the TTI is achieving approximately 18% of testing level and 43% of tracing level. And calibrating later on, the TTI is achieving approximately 26% testing level and a 47% tracing level. So they're both increasing. It's a mathematical model. I have to discuss limitations and I have to discuss assumptions that gave these results. There are obviously assumptions around parameters, their distributions, and how they are collated, how they are based on collated information across different studies, different settings. Symptomatic infections in our study are assumed to account for 70% of onward transmitted infections, based again on the information that is available to date. We still don't know what is the actual number of symptomatic versus asymptomatic infections. The probability of developing clinical symptoms is assumed to increase from around 20% in children under 10 to more than 70% in older adults. We importantly assume that 70% of the workplace will be going back as schools reopen, and we are wary that this may be overestimating. And finally, by using the current levels of tracing that is available on the NHS Test and Trace website, we can estimate that the actual tracing coverage was 43% for June and 47% for July. And this is a product of the percentage of people tested positive that were interviewed, percentage of these that reported contacts, and then the percentage of these contacts being traced. Nonetheless, with these assumptions, with these limitations, we are showing that we are the first study that can quantify the amount of testing and tracing that is necessary to prevent a potential second wave of COVID-19 in the UK under different strategies of reopening schools, and importantly, under the current strategy as schools reopen late last month or this month. We know that schools need to reopen to protect children's development, and it is important to do the best in keeping R less than 1 and keeping this spread of the virus intact. So we need to consider this. So in considering this, we are taking, so this is work that is new and it's ongoing. we are asking ourselves, well, what other questions can we ask that align to this that we should be looking at? And the obvious questions are, as some secondary schools are, as the policy on masks for secondary schools is in place, we are asking, how about masks? What role do they play in mitigating the spread, and what is the impact of having them? What trade-offs in schools, work and society reopening may be needed as schools reopen? And there is loads of other questions. These are just some questions, and what I'm showing here is illustrative graphs, almost sketched, that if we consider different scenarios, we get different answers. I will briefly tell you about the work that's ongoing at the moment and is due to be submitted for publication shortly. Again, we have the same network model that we have. We are adapting Covasim in order to look at the impact of wearing masks, where we model wearing of masks as reduction in the risk of exposure to the virus for those people that move from susceptible people. I'm just going to show you these results briefly, and what I'd like you to note and take home message from this is that the blue region increases if we wear a mask, which means that we are getting a combination, a larger combination of test and trace combinations where we can control the virus. As I said, Covasim model is a large collaboration among many people. The code is available there. We have a web-based app that is available there, and we are currently working full steam ahead, collaborating with people across different countries. So it's a global model, and as a global model, I only have space to thank a few people who've been crucial in developing the model and adapting it for the purposes of this study. There is many more that I'd like to thank, and the many others consist those people. And of course, thanks to you for listening to me.